Hey everyone, today I'm going to talk about the question, describe the respiratory response to hypoxemia in both the awake and anaesthetised patient. So the way I interpret this question is that the examiner wants us to describe the control of ventilation, because if you understand the control of ventilation, then you can understand how hypoxemia would augment this. And then by describing all of this, you can then understand how an anaesthetic that's given to a patient could augment the control of ventilation and the effects of hypoxemia on this. So if we talk about the control of ventilation, this is a sensor, integrator, effector system. So our sensors can be divided up into central and peripheral, with central being our ventral medulla, which is sensitive to CO2. But remember, it's not the central medulla or the ventral medulla actually sensing CO2. It's the fact that CO2 can cross the CSF easily. Through our Henderson-Hasselbalch equation, you will then lead to more hydrogen ions, which will mean that your CSF is more acidic, and your ventral medulla, it senses the acidity and then stimulates respiration. And it's not the CO2 that directly stimulates respiration here. Then you have peripheral chemoreceptors, and these are in the carotid bodies and the aortic bodies. And the carotid bodies are innervated by cranial nerve 9, which is glossopharyngeal, while the aortic bodies are innervated by cranial nerve 10, which is the vagus nerve. So the peripheral chemoreceptors, through type 1 glomus cells, are responsive to decreased partial pressure of oxygen, which it's important to note here is not the content of oxygen that stimulates it. So in times or examples of anemia itself doesn't stimulate the hypoxic response because you still have the same partial pressures even though the content of oxygen is less. It's also sensitive to the partial pressure of CO2 as well with increases. And it can also sense decreases in pH as well, but this is usually described in physiology textbooks as only being a function of the carotid bodies. It's important to note with the peripheral chemoreceptors that they have a really high blood flow of about 2000 ml per minute per 100 grams, which is important because it means that their cellular function doesn't actually take up a lot of the oxygen that's in the blood there, so they're not just sensing deoxygenated blood that they've taken up. So their supply of oxygen is essentially the dissolved oxygen portion, not the partial pressure oxygen. So these sensors will then feed back into an integrator system, which is in the medulla. So you have the medullary and the pontine respiratory centers. And these will lead to effectors. And specifically, you can say the diaphragm for inspiration, the internal intercostals for expiration, while external intercostals for inspiration, your abdominal muscles as well for forced expiration, and your accessory muscles when you need increased worker breathing and increased inspiration and expiration, but more specifically, inspiration. And then these effects will either lead to an increase or decreased rest rate, depending on whether your CO2 is high or low, or you're hypoxic or not hypoxic. And then this will correct or be sensed by the sensors and be a negative feedback system. Now, we've mentioned two sensor systems here, your peripheral and your central. Just as a side note to mention, your peripheral chemoreceptors provide a more immediate response to, say, hypoxia or changes in CO2, but it's a weaker response and it's less prolonged. So it accounts for about 20% of your expected respiratory response to the change, while your central chemoreceptors, which are sensitive to PaCO2, but not directly PaCO2, it's through that crossing of the CSF, making the CSF more acidic, they account for about an 80% response, and it's a more prolonged response. So now we understand the controls of ventilation and respiration. We can then apply this and think about how hypoxemia will augment and change this. So hypoxemia is usually defined as a PaO2 less than 60 millimeters of mercury. And this is important because on the oxygen haemoglobin dissociation curve, this is about 90% saturation and is the steep part of the curve. So for every millimeter drop, you're going to have a substantial drop in saturation. So if we were to graph this and we put on the y-axis minute ventilation in liters per minute, And on the x-axis, we would have put PaO2 in millimeters of mercury. Now, our important point here is the 60 millimeter of mercury mark. And you can see that as oxygen, or the partial pressure of oxygen, drops, the minute ventilation remains very steady and stable up until 60 millimeters of mercury, where there's a sudden increase in minute ventilation. Now, this would be the case if your PaCO2 was also normal at about 40 millimeters of mercury. But then let's augment this again, and let's make the PaCO2 60 millimeters of mercury. So we can see at our baseline, we already have a higher respiratory rate because our minute ventilation is increased. But then our point at which hypoxia stimulates increased minute ventilation has now gone from about 60 to about 75 to 80, which points out an important point that when you have hypercapnia, your sensitivity to hypoxia is more sensitive. So you have a faster response and a more sensitive response. So this is also described as a synergistic relationship. Now we can relate this to someone receiving a general anesthesia. As a general rule, all anaesthetic drugs, whether IV or inhalational, will depress the response to hypoxemia and also hypercapnia. I'll use the example of giving someone an inhalational anaesthetic, and we talk about minimum alveolar concentration, also known as MAC. So we'll go for two extremes, a MAC of 0.1 and a MAC of 1.1. So if we draw a MAC of 0.1 on our graph, we can see that it is pretty steady, but now our inflection point is less steep for hypoxia or hypoxemia, and it occurs at a lower PaO2 as well. So it's been blunted here. This would largely be the same as well if there was hypercapnia, but it might just move up and down the y-axis depending on this. Generally, a MAC of 0.1 depresses your response by about 50 to 70%. So a MAC of 0.1 is quite a light anaesthetic. So if we go to a MAC of 1.1, it almost completely obliterates your response to hypoxemia and hypercapnia. As you can see, the line here is almost completely flat. So this is important clinically because when someone is being extubated and then put into recovery post their anaesthetic, they may still have some anaesthetic lingering around. And if they have even a small amount of a 0.1 MAC lingering around, then they potentially will have a respiratory depression or depressed response to hypoxemia and hypercapnia, meaning that their ventilatory drive is a lot less. So they'll need appropriate monitoring and likely supplemental oxygen to prevent hypoxemia while they're in the recovery area. Now, this next part is something that I wouldn't really expect to be a part of this question, but in previous exam reports from ANSCA, they mentioned that this wasn't mentioned by candidates, and this is hypoxic pulmonary vasoconstriction. So I'll just touch on this briefly. So hypoxic pulmonary vasoconstriction is the response to the pulmonary vasculature to hypoxia. Now, specifically, it's actually the decrease in alveolar partial pressure for oxygen that's the major influence here, because you already have deoxygenated blood entering the lungs anyway. So that blood is deoxygenated, and if your lungs were sensitive, or the pulmonary vasculature was sensitive to hypoxia on the vascular side of things, you would expect vasoconstriction throughout the entire lungs. But it is hypothesized that there is a small influence from hypoxia if it's less than normal within that venous circulation that goes into the lungs as well. But the major influence here is decreased alveolar partial pressure of oxygen. So there's a biphasic response to decreased partial pressure oxygen in the alveolus. There's a rapid vasoconstriction of small arterioles that begins within seconds, with a plateau that's reached at about 5 minutes. Then there's a second phase that occurs at around 40 minutes to an hour, with a maximal response at 2 to 4 hours. The mechanism is unclear. It's thought that it involves endothelial production of endothelin, which would cause vasoconstriction, or nitric oxide, which usually causes vasodilation. And the role of hypoxic pulmonary vasoconstriction is to improve VQ matching, so reducing the amount of blood that goes to hypoxic areas of the lungs or poorly ventilated areas of the lungs to improve perfusion to areas with good ventilation so that that blood can be oxygenated. It also increases pulmonary pressures. So in terms of anaesthetics, volatile anaesthetics are known to disrupt the normal mechanisms behind hypoxic pulmonary vasoconstriction. And usually it's agent dependent, with halothane being the most potent and sevoflurane being less disruptive. And it's said that a MAC of 1 causes around a 20% inhibition of hypoxic pulmonary vasoconstriction, though in someone who's intubated, ventilated, the clinical significance isn't very obvious or it is disputed. And IV anaesthetics don't affect hypoxic pulmonary vasoconstriction. So lastly, I'll just touch on this just as an interest and just in case you ever asked it in a viva, but sometimes you might be asked about the time course and response to hypoxia or hypoxaemia. So what you would do is on the y-axis, you would draw minute ventilation again in litres per minute. And on the x-axis, you would draw from 0 to 8 hours. So this is for someone who has been made hypoxic to about a SATS of about 80%. And when this occurs, there's two responses that can happen depending on the reaction or the response of CO2 in these scenarios. So in someone where the pCO2 has been kept constant, so isocapnic, you'll see three responses or a triphasic response. You'll see an acute hypoxic response, which occurs over seconds to minutes, and this leads to an increase in respiratory rate. And then over 20 to 30 minutes, there is a decline, though the plateau or the new baseline is higher than previous. And then because the CO2 has remained elevated, the rest rate will continue to rise. And at about that 8-hour mark, it will be at its peak, and this will be sustained. And this is said to be sustained or peak at around 28 to 24 hours. If the CO2 is able to correct itself, and this is called poikilocapnia, then you'll see more of a biphasic response, where you'll still see that immediate over seconds to minute hypoxic response with the respiratory rate increase, but it will be less strong compared to the isocapnic response. And then it will plateau over that 20 to 30 minutes. And then there will be a new baseline set with a higher minute ventilation that continues throughout. So that essentially answers that question in quite a lot of detail. In a later video, I'll go further into carbon dioxide and how that controls ventilation and what the effects of hypoxia are on the other direction to hypocapnia and its control of ventilation, as well as metabolic acidosis, which is another topic that comes up in the exams.